Mr. Chairman, dear guests, ladies and gentlemen, I would like to present one case, but before that I have to say that we've got a chance to assess efficacy of Simeox therapy for 2 months, and we were able to perform the therapy in a group of about 15 patients. There were patients with COPD, with cystic fibrosis, but also we have 2 or 3 patients with pulmonary fibrosis, the diagnosis which is not usually expected to have a huge amount of expectorated sputum. However, I would like to present you one case of such a patient with pulmonary fibrosis and present the results of that therapy in such a kind of patients who are not usually have a huge expectoration. And dear guests, if you agree, we are in Poland and we have a translation. So if you allow me to continue my presentation in Polish, I will start the rest of my presentation in Polish.
With cryptogenic organizing pneumonia. This was confirmed with open lung biopsy, so we're quite certain of this diagnosis. After a short period of treatment, the patient was lost to follow-up, but in 2009 he was also diagnosed with rheumatoid arthritis, and he was started on azathioprine and methylprednisolone. After that, he was only followed as an outpatient until 2017, but in the meantime, the patient was diagnosed with usual interstitial pneumonia, most likely in the course of RA, and he also has type 2 diabetes mellitus, osteoporosis, and he has sustained 2 strokes. Until 2017, as I said, he was in outpatient care, but late in 2017 his condition deteriorated. He was hospitalized at the Institute of Tuberculosis because of reduced exercise tolerance, severe dyspnea, hemoptysis, and expectoration of large amounts of purulent sputum. Those are his basic lab work results. Both the blood count and the clinical chemistry. He had a leukocytosis, an elevated CRP level, and certain indices typical for active rheumatoid arthritis. His D-dimers and BNP were elevated. His blood gases were fortunately not severely abnormal, and in his chest X-ray we could confirm his earlier confirmed diagnosis, interstitial lung disease in the course of RA, most likely. So this is his baseline chest X-ray. He had a fine network of opacities, especially in the peripheral lung fields, and his HRCT showed classical hallmarks of UIP with the honeycombing network pattern. And what is most important in this presentation, based on this evaluation, we also were able to confirm that he had traction bronchiectases, which also go along with this interstitial disease pattern. We performed fibrotic bronchoscopy because he had hemoptysis. We found intensive inflammation, a lot of purulent discharge, and friable mucosa, and something that the endoscopist stated was excessive compliance or decreased rigidity of the posterior wall of the trachea. He was found to have a fungal infection, Aspergillus fumigatus. He got appropriate treatment, but also rehabilitation. Since we had access to Simeox as of late 2017, we also applied this as a way to evacuate his mucous bronchial discharge. And we evaluated the patient with functional tests, pre and post Simeox. We assessed the change of ventilation parameters between the 3rd and the 10th of November 2017. I just want to point out several parameters of the workup that's given here. Forced vital capacity was elevated by 100 mils. That's clinically significant. Also, FEV1 elevated by about 70 mils. We also measured his airway resistance, and it clinically significantly decreased. What also seems important, there is an improvement of total lung capacity that we found by over half a liter. So in terms of ventilation parameters, 7 days of therapy, I underscore the patient was on antibiotic treatment, which of course also contributed to the positive outcome, but it seems to me that respiratory rehabilitation with Simeox also contributed. We also tried to assess quality of life by CAT. That's the COPD assessment test. This tool is dedicated to COPD patient evaluation, but in recent years it has also been used to assess the change of quality of life in patients with other diagnoses. And it turned out that the quality of life of this patient improved from 23 points to only 12 following therapy. I want to point out 3 domains that are important for our patient in this test. This was not a COPD patient. The first domain was cough. There was a significant reduction of cough intensity as evaluated by the patient after 7 days of such therapy. What is also worth evaluating, the volume of expectorated sputum was reduced, which was also positively assessed by the patient, and the perception of dyspnea. Here, the patient also reported a reduction of dyspnea in terms of a complete reduction of dyspnea. Clinically, the patient was able to have a longer walking distance. Before treatment, he had a small tendency to desaturate, and on his 6-minute walking test, there was no desaturation after the rehabilitation, and the Borg scale also improved from 2 to 1, and the pulse rate during the 6-minute walk test, heart rate clearly improved following therapy as compared to what was found before treatment. So based on just one case, I will venture the following conclusions. Not only patients with bronchiectasis in the course of cystic fibrosis, which is obvious, not only patients with COPD who may have bronchiectasis as part of the disease, but we also think that patients with interstitial lung disease who have traction bronchiectasis may benefit from Simeox therapy. In our concrete case, a 7-day course of therapy with Simeox brought about clinical improvement as assessed by ventilation parameters. We had an improvement of FVC, airway resistance and total lung capacity, and there was also an improved quality of life as assessed by CAT, and an improved exercise tolerance as assessed by a 6-minute walk test. The patient tolerated the device very well, and it's also important the appliance was easy to use by, I reiterate, a 70-year-old man who sustained 2 cerebral strokes, so he was less dexterous than many other patients would be.
Thank you very much. This is a very simple presentation based on just one case, but I think it's very important to show that not only patients with cystic fibrosis or COPD and severe bronchiectasis may benefit from the therapy with Simeox, but also patients who are not usually, as I said, expected to have a big expectoration of CO2. And to finish, I would like to thank you, PhysioAssist, for organizing this session, for coming to Poland, to Warsaw, and I would like to thank all guests, our famous guests, to give their talks and to show us your experience with a new and I think very promising therapy in pulmonary rehabilitation. Thank you very much.